In order to ensure that everyone can clearly hear the presenter and hopefully avoid any technical difficulties, though we are already experiencing some today, it's really important, especially today, that you mute yourself if you've called in using the phone, and you do that by pressing *# or hitting the mute feature on your phone. Again, this is really important today because I'm unable to mute you. So just in order to avoid any distractions or hear any background noise, and we can all clearly hear Doug, again, mute yourself by pressing *# or the mute feature on your phone. If you get too rowdy today, we'll give you a warning. But if not, I might have to kick you off, and I don't want to do that. So again, just make sure you mute yourself today. I really appreciate it. If you have any questions, comments, reactions to the presentation, we encourage you to share those in the Q&A pod, which you'll find in the lower left-hand corner of the next screen that'll come up. And David and I will help field those towards the end of the presentation. We'll also be sharing the presentation at the end for you to download, and you can download that directly from the webinar in the file pod, but I'll also send it out afterwards in an email along with the transcript and recording link. Thanks again for joining us, and I think I'll hand it over to David to introduce our speaker.
Thank you, Jessica. And again, we appreciate the support of the Iowa Coalition for Integrated Employment to help make these webinars accessible for everyone. We're really pleased to have Doug Crandell with us today. Doug is a nationally recognized subject matter expert in many areas. His expertise today, though, will be sharing information about individual placements and supports, evidence-based practices for working with individuals with mental illness. These webinars are really powerful tools, and we're fortunate in Iowa to have access to these through the support of the Office of Disability and Employment Policy. So we're really glad that you are with us today to take advantage of this. Doug is a senior consultant with Griffin-Hammis Associates. He's also on the faculty of the Institute of Human Development and Disability at the University of Georgia. He really provides training and technical assistance with evidence-based practices in the areas of employment supports. He really has a varied background, but specifically for today's topic, you'll be interested in knowing that he's managed, staffed, and directed community mental health and disability programs at the provider level with a real focus on customized and evidence-based practices for people with disabilities, specifically individuals with mental illness and their employers. He's also a recognized author, published multiple books on disability and mental illness. We're really happy that he'll be here today to share some information on working with individuals with mental illness and how we can do better in helping individuals achieve individualized competitive employment. So Doug, welcome to Iowa, and we really appreciate your willingness to work with us. So I'll turn it over to you.
Well, thank you, David, so much. What a kind and generous introduction. I am honored to spend time with you today and want to thank Jessica for all the technical support. I just cannot fathom how I would manage trying to have a large webinar like this and be responsible for the details. So thank you, Jessica. Well, I do feel like I am from Iowa, and I'll tell you why. Not only do I respect all the work that you've done there and know many of your folks and have connections to Iowa, but here in the South, even people I've known for 20 years sometimes introduce me as being from Iowa when I'm actually from Indiana. But in their minds, it's pigs and corn, and now I just let them say Iowa. So hopefully I am an honorary Iowan today. Well, as David said, I have worked, be celebrating my 25th year this fall in employment services, and I continue to learn from many people myself and how we can better do what it is that we're charged with changing in our systems. And most of those 25 years, 20 of those have been with providers, both in Indiana and Georgia, and always have worked with providers both in mental health and IDDD. So as you'll see, while we still, as systems, are trying to talk about evidence-based practices and being more person-centered and customizing things, this IPS, this individual placements and supports, evidence-based supported employment, has some very familiar core principles. And I think you'll see that there is a crosswalk, if you will, between other best practices and evidence-based practices in employment. In the last 5 years, so what I've done here in Georgia is provide all the training and technical assistance under our Department of Justice settlement. And in that Department of Justice settlement, it says that, among many other things, that the state of Georgia must use evidence-based supported employment within its mental health systems. So in other words, not just any employment would work, not just any supported employment program would work, but an evidence-based IPS supported employment program. Now, what's interesting about that is if you have been in mental health and worked in community mental health agencies or collaborated with them, you know that they have a very similar challenge as lots of other parts of our employment and disability system, and that is in community mental health, we've kind of believed that a person enters the system, yes, and then they incrementally get better through treatment and programs and a multidisciplinary team. And then at the end of that time, as the person gets incrementally better, they are magically discharged, and employment has been an aftercare issue if you look at the way we've organized our community mental health system in the United States. So one of the things that's so important to understand is just like IDDD systems, just like lots of our state agencies, federal agencies, the challenge to community mental health is to think of employment as essential to treatment, essential to recovery. And that is something really pretty brand new. Have we had supported employment programs in mental health agencies over the last couple decades? Absolutely. But we haven't looked at it from this evidence-based approach saying that true recovery, yes, and treatment is when employment happens up front, not as an aftercare issue. The challenge then is we still have many of our systems organized around employment as aftercare. And so when you try to lay this evidence-based approach over that system, there are some things to be mindful of, some pitfalls that you can avoid. In my training and technical assistance I do with the community mental health agencies here in Georgia, my very, very favorite part is doing the immersion or the field work. And I'm often with brand new employment specialists in mental health, and they are doing job development or attending treatment team meetings or working with their local VR office. And there's something that always pops out, and that is people don't really understand how important employment can be and is in recovery right at the onset of entering a mental health system. And so as we talk about this today, I'd kind of challenge you to sit back, relax, maybe mute your devices as well as your phones so Jessica doesn't have to kick off the rowdy folks, and think purposefully about some of this material. Some of it's probably not new to many of you, but I think the thought-provoking part is implementation. And it's difficult to get to implementation and taking things to scale, if you will, if we don't understand kind of the foundation. So let's get started. We're going to cover some core principles, some KSAs, knowledge, skills, and abilities associated with implementation of this approach. And I do emphasize approach. I think calling it a model makes it sound too rigid, and you'll see. And if you're practicing some of this yourself, there is room for innovation in an evidence-based approach. And then we're going to look at some work really out of a community of excellence in Ohio around levels of engagement in evidence-based supported employment. So we've agreed that certainly type in questions comments, reactions, and we're going to allow some time near the end of the webinar to hopefully address those. So I wanted to start off with just a quick little anecdote, and that is that while I grew up on the pig farm in Indiana, when it came time to go to college, I had to work in the summers off the farm, and I joined my father at a ceiling tile factory. And one of the first people I met there was a man, and this may sound a little strange, so get ready for it, was a man who had been in the union, worked at the ceiling tile factory for 30 plus years, and the way he communicated was by barking. So I'll say it again because it's a little shocking, I know. But he barked in different dog voices, if you will, and that's the way he communicated. And I often say to people, can you imagine if somebody who came into your office, VR office, mental health office, clinic, and they barked? What kind of treatment plans and all of that we would develop around that person, really trying to eradicate that behavior before the person could go to work, because we might rightly say to ourselves, someone's not going to accept that in the workplace. And if there's one thing I've learned over the last 25 years, we do not have to worry about burning bridges with employers. We do have to make sure we meet their needs and discuss concerns, but mental illness and disability does not happen in a vacuum. It is not separate from the community, just as businesses are not separate from the community. And so because it's natural, there are plenty of people who work every day with things that we might rule out in our mental health system as being appropriate for work. So with that, let's get started here, have a little time to kind of ponder this idea. So we're going to look first at these core principles of evidence-based supported employment, the competencies, right? And there's a way that I think about this that I think is helpful. And you'll see this in the very first core principle, which is known as zero exclusion, which many of us understand. So you can see that the approach in IPS, in evidence-based supported employment, is grounded in values, like much of what we do, like general supported employment was supposed to be, right? And those values then drive the core principles, the creation of these core principles. Those principles then in turn, yes, define metrics, define measurements. And that's one of the things that sets evidence-based supported employment apart from general supported employment. There are things that we measure, that we must measure to implement and to check with a Fidelity assessment where we're at. Now, those measurements then outline how we implement an evidence-based supported employment program. And then finally, as I've mentioned, this tool that we examine how well we're implementing IPS supported employment within a mental health agency, that Fidelity examines how well we're doing that. And there was a pretty big shift several years ago where that Fidelity instrument, the way that an organization was measured, moved from just the programmatic, in other words, just a supported employment department, to an overall agency, the overall community mental health system. And that is where, as I mentioned before, we are pushing through these kinds of employment supports to fundamentally shift the way mental health organizations in the United States think about employment related to treatment and recovery. And this is what we'll use as we move forward today, this idea that the values, the metrics, the implementation are all tied together and then end up with us being able to see how well we're doing it. So oftentimes, if people are not familiar with the Fidelity instrument, the way that an organization gets graded, because there is a numeric number, there is a numeric total for how well we're implementing these pieces, often people want some summaries. So I think these 4 bullets pretty much capture what we're talking about when we talk about measuring what we do. So how do employment specialists perform specific functions of their job? Job development, assertive engagement, participation within the team, how they do that collaboratively with inside a mental health agency and with VR and how well they do that, how employer engagement is performed and tracked. So one of the things that we found out here in my home state of Georgia is prior to implementing IPS Supportive Employment, if you looked at the numbers, some folks in the community mental health agencies might be waiting 2 years, up to 24 months after they stated they were interested in going to work. Now, that's not good customer service, whether you have a disability or a mental illness or not. And so for the first time, right, we look at when someone says, I'm ready to go to work, and that's their decision, how quickly are we doing that? And then finally, as I've mentioned, the agency's performance related to these core competencies is measured as well. It is not simply a programmatic review, but a review of how well the mental health agency is focusing on employment. So that's a summary, right, of kind of the Fidelity points. Now here are our core principles. That first one, focus on competitive employment. We obviously know what that means. That means a real job. You see zero exclusion there. In other words, the way you're eligible for this service is because you were choosing when is the right time to go to work. And we'll see in mental health and VR systems, when they start collaborating around this approach, you might imagine this is the one that gets lots of discussion. Eligibility based on choice, that idea of zero exclusion, mandates that we work as a team, because an employment specialist, a VR counselor, and a clinician alone cannot keep somebody employed who has multiple mental health barriers to employment. And you'll see a little bit of the research around this as well. So the integration of this idea of rehabilitation and mental health, attention to preferences, a person-centeredness, right? Obviously benefits counseling, rapid job search, that there's a way to look at the rapidity of what we do in a way that is connected to when that person says they're ready. We look at systematically engaging employers, right? We don't only rely on labor-driven jobs or what's available in the community. We must tailor and be person-centered around which employers we're talking to. And then finally, for many of the people we support, this idea of time unlimited, the person makes the choice, along with feedback from the interdisciplinary team about when they no longer need intensive IPS supports, that other mental health practitioners, other natural supports might step in. And those are the core principles that we're challenged to implement. Now, I mentioned to you that I do webinars on IPS Supported Employment here in Georgia before we do the field work, the immersion work. And those webinars really cover the core principles. But attendees in webinars, much like you are today, and certainly I attend and participate, often will kind of get disengaged during the presentation. So I'm going to do something that I do quite often. I'm going to read to you a very short paragraph. And I think it captures, before we move on, in just a few sentences, the essence of evidence-based supported employment. This reading comes to us from a great textbook called Modern Community Mental Health. The textbook is called Modern Community Mental Health, and it is published by Oxford University Press and from 2013. But listen to the description of IPS in this text. IPS supported employment is a team-based approach. The employment specialist joins one or more multidisciplinary teams, such as case management, assertive community treatment, intensive case management, supported housing, and other types of teams. Rather than providing the vocational services alone, the employment specialist galvanizes the team to consider work as an essential part of recovery, one needing everyone's attention. I love that word, that the employment specialist must galvanize that team, galvanize the team to consider work as an essential part of treatment and recovery. To me, that may be the best definition of our work in mental health around employment. It cannot be done alone, and in fact, when you try to do it that way, your competitive employment rates fall. Okay, so let's look real quickly at the employment specialist and the phases of supported employment. In IPS supported employment, those are not broken out. There's not a job developer, and then a job coach, and then a follow-along person. The employment specialist is responsible for all those phases until we get to that point when the person no longer needs intensive IPS supported employment and the team decides how, along with the person, the long-term supports will go. Here's another metric in employment specialist related to evidence-based supported employment, and that's 20 or fewer job seekers. Obviously, we know why that's the case, because when we have over 20, we tend not to be able to individualize and personalize the supports. Now, employment specialists in this IPS approach, and they are rated on it, right, only provide supported employment. So in many community mental health agencies, though, these positions are hybrid. They might have some case management attached. They might also, in some cases, be supporting other job seekers with different disabilities than mental health. And when that happens, that does impact the delivery. So the very first thing people say is, well, we have employment specialists that have 35 people that they're working with. And that's the trick, yes, because obviously that comes back to funding. But in IPS, we know that we are supporting folks sometimes with multiple barriers, and we must have to stay to true fidelity in the approach, 20 or fewer. And that's the role of the employment specialist within IPS supported employment. Okay, so now we're going to look at these competencies. And when I talk about these competencies, I am talking about the employment specialist, but you'll see, because IPS is a team-based approach, that many of these competencies then link to other mental health clinicians, VR staff, ancillary support. But for today's discussion, I want you to kind of think of these for the employment specialist. So in terms of this integration competency, the idea that supported employment's not just an add-on, right? A great example of this was I was on a state on the East Coast, and I was talking to the community mental health agency, and the clinical director wasn't sure if they had a supported employment program because it was so disconnected from the mental health agency itself. Now, it turns out that they did. They actually had 2 employment specialists, and they were employees of the community mental health agency. But my point is that in the past, we've added it on instead of looking at this as a way to connect the interdisciplinary team. So in Fidelity to the model, employment specialists are part of up to 2 mental health teams. Over that amount, if you're taking referrals from 4 or 5 mental health treatment teams, interdisciplinary teams, then you're going to get a lower score in the Fidelity review. And the thing that we know is, you'll see, the lower the Fidelity score, the lower the competitive employment rates for job seekers with persistent and severe mental illness. So the knowledge, skills, and abilities, the KSAs associated with this integration competency, obviously you got to know what a multidisciplinary team is and how they function. I've seen employment specialists, I go along with them to the treatment team, and they don't feel like they have an expertise to offer. So they're not really fully involved. Skillful in communicating, galvanizing that team is important because you're working with other disciplines, and you have to be able to communicate well with those folks. And then to really look at employment and its possibility immediately with the right supports and focus, immediately. It's easy to go to a treatment team meeting and talk about employment for the person sometime in the future, but that's not what we do. If the person makes a decision they're ready to go to work, the team then must support that, and that's a fundamental shift in the way that we've looked at employment. Okay, so the rehabilitation competency. There is a item in the Fidelity review that is directly scored with the quality, the consistency in which an employment specialist at a community mental health agency engages their local VR counselor. Now, obviously, community mental health and voc rehab operate in very different realms. They have different ways in different states of how they process people through, make people eligible, all of that. So one of the critical pieces is making sure that people understand VR and its processes locally, that they understand the way that you coordinate with VR is to have rapid and seamless collaboration, sharing eligibility. Some states call that presumptive eligibility. To be able to navigate those two systems with jointly supported job seekers, and the ability to keep the VR counselor involved and engaged and informed, both by their participation in the treatment team, but by simply having a knowledge of the requirements of VR. The choice competency, as I mentioned, is always one that comes up when we start collaborating more between mental health and VR. And the only way I know to help people sort of get rid of their ideas that this may not mesh well is to understand the research around IPS supported employment, to know that we've done a horrible job supporting these job seekers both in mental health and in voc rehab and in other settings. So we have to have a skill in rapidly finding employment after another job has ended, and that happens a lot in IPS supported employment. And to be able to really communicate this idea of zero exclusion in practice, the idea that, yes, this person has a lot of barriers, but if we act as a team rather than a lone employment specialist, the choice of that person can be honored. Disclosure in IPS is taken very seriously. I think it's a real model for the way that we need to be looking at disclosure across all disabilities. And inside the career profile, there's a whole pros and cons of disclosing, and someone needs to be able to have that discussion with a person so that they are making an informed choice about when to disclose, what to disclose, or if anything is disclosed. And that is really important around accommodations in the work site, and it's important around decisions that the job seeker might have to make if they choose not to disclose, they don't want the employment specialist help at all except off-site, and then that job seeker is having a great deal of trouble finding a job. If that's the case, the team needs to come back and again review the pros and cons. And finally, in this disclosure competency, there's nothing better than someone who has navigated this themselves, peer specialist, recovery staff, who can help that job seeker make some decisions around disclosure. The career planning competency is a direct crosswalk around person-centeredness to customized employment, to really good general supported employment, to good transition services regardless of the student's disability or mental illness. So career planning is a process here that I think many of us know, but in mental health we've skipped over it in lieu of that whole idea of discharging people after treatment. So career planning, obviously, you have to be able to encourage other team members, VR and mental health clinicians, and in some case, doctors and nurses who are prescribers, to focus on the person's strengths, yes? Because this comes in direct conflict with how we've done employment and mental health in the past. And we want to rely on good person-centered career planning, because once the team decides that, oh, well, the person needs to do work adjustment or some more day treatment or a psychosocial clubhouse model, then we've already violated that zero exclusion. That eligibility is based on when the person says they're ready to go to work. You have to have the ability to do that in the career planning competency. Rapid engagement is the one that employment specialists will tell you they feel the pressure on. And you'll see here that there's a focus on getting the person in front of an employer within 30 days, of scheduling 6 or more face-to-face employer contacts each week. This is what I really work on with people in the field, and that is that engaging employers around a job seeker with a mental illness from a good, solid career profile requires big surprise, right? Scheduling. And being able to efficiently record those efforts, because those field notes really have to populate the VR and mental health data collection systems. It has to be there for us to see how well a specific program is doing all of those. And that has to be balanced, Jeff, as we do in a lot of programs with multiple job seekers. And there's an ebb and flow that I can tell when a person understands that one week they're going to focus on these 2 or 3 job seekers and the next 2 or 3 others. So there's still a caseload of 20 or less. So these folks have to be really skillful in balancing that career profiling piece with face-to-face employer contact. The long-term support competency has mostly to do in IPS with enlisting other team members in problem solving, if it's around medication changes or natural supports, benefits issues. Many, many times people will struggle with motivation and need encouragement from peer and recovery supports. You have to be skillful in pulling that in, because that is a very strong indicator that that person will have some longevity on the job. So these KSAs, these knowledge, skills, and abilities, as it's related to long-term support, is embedded within that treatment team, within that interdisciplinary team. And so if you go back to the definition that we read, we said it ended with that work is an issue, a part of recovery that needs everyone's attention. And so this fundamentally shifts what a case manager might do, what a residential support person might do as well. The outreach competencies are really important once that person has made that decision that either they don't need supports any longer, right, or the team helps in that discussion, or somebody is having trouble up front. They say, yes, I want to go to work, and we see this all the time in mental health, and then we can't find the person. We don't hear from the person, particularly if they're in outpatient setting or some other settings that are not as inclusive of the person's life, like supported housing or intensive case management. So understanding assertive engagement and motivation, understanding that many of us struggle with that. So you have to understand that we're not just going to discharge somebody when they don't show up for an appointment. And the systems, both VR and mental health, sometimes struggle with that. So do clinicians. Using recovery tools, so RAP for work is very important, including recovery support staff or certified peer specialists. That a whole idea of having the ability to re-engage a job seeker that has become discouraged or less motivated. That is the core reason in IPS Supportive Employment that we have a rapid engagement approach, because we know not only do job seekers with severe and persistent mental illness struggle with that, we all do, right? If you've ever been unemployed, it can be very discouraging, right? And so you have to be able to work in conjunction with that team to do that assertive engagement, to really understand the core principles around motivation. Now, this slide, my friends, really focuses on just some anecdotal data that we've gathered over the last 5 or 10 years, and that is what other KSAs outside of the core principles and the competencies we just looked at indicate a high-performing employment specialist. Well, in this model, people who can change what they're doing based on data, their job development, their employment rates, their overall rapidity of how they're engaging the folks on their caseload. Somebody who has a strong grasp of system-specific language tends to do really well in this. They can speak VR, they can speak mental health, they can speak recovery and IPS, and the ability to translate that information between the systems, right? They have to be truly masterful in timelines and scheduling because this approach really demands that the things we're doing be measured. And what I have found that I think is something that we could do more and more on across the kind of direct support professional role is high emotional intelligence, right? Someone who can build social capital. We used to call this playing nice, but truly being able to connect with people in an emotional way using intelligence that brings everybody to the table, galvanizes them. And then finally, this last one really speaks to where there might be a connection outside of IPS supported employment to further customization. And we see this a lot with job seekers with severe and persistent mental illness who've been in day programs for a couple decades, who've maybe been on older psychotropics, who have co-occurring issues, that some might be cognitive disabilities, that we know that that person can recognize, that employment specialist can recognize, I'm going to have to customize this more than I can in simply doing IPS. Okay, so the 8 core principles, you can't divorce yourself from those that we went over. You can't just do a little or a few of them, right? If you don't believe in zero exclusion, you're going to get much less competitive employment rates. Again, it's a specific type of supported employment. I think you get that now. It does sidestep work adjustment and prerequisites, pre-vocational, transitional employment, group models, and it's been researched. So a Fidelity review, for those of you who are not haven't experienced this, is again a scale that measures kind of as a roadmap or a compass how well we're doing and how we can improve. So there's always an ability to improve what we're doing, and there's feedback from that Fidelity review. We understand as a community mental health agency how well we're doing, not just in supported employment, but as the entire team being involved in work and recovery. Just quickly, this is the research. I think if you've studied any of this, you know a lot of this comes from Dr. Gary Bond, great guy from Indiana who's working at Dartmouth now. These randomized controlled trials, as you see, if we decide to do it the old way, without a team-based approach, without measuring what we're doing, then we're only going to get about 25% of these job seekers to work. If we use IPS, we're going to get upwards to 60%. This is a learning collaborative that I found really interesting, and this means sites across the country, 88 of them, that we're just learning to do IPS, just learning. And as you can see there on the left, this is what you get in a Fidelity review. You can get something that's called not supported employment. You're not doing supported employment, right? You're not adhering to the core principles, all the way to exemplary. And as you see, even in these learning sites, even in places that are just implementing it, the competitive employment rate rises with the better fidelity to the approach. This one is my favorite piece of research, and arguably it's small, but I'm just fascinated by it, right? So this was also conducted and developed by Dartmouth, but it looks at a program in Oregon and looks at folks who have lots of barriers. You see that first bullet where 60% had co-occurring disorders, had substance abuse disorders, 70% had those histories of felony convictions, and they decided as a team they were truly going to stay focused on recovery and employment and truly use the team, really use the team in a way it's intended to be used in IPS. And you see the impact. 71% of the 319 folks were successful in securing employment over 2 years and almost $10 an hour. So they blew the randomized controlled trials out of the water, right? Not 60%, but 71% because they truly collaborated around these job seekers with multiple barriers to work. these are the metrics that I always tell people you should know for your agency, for your program, and your own caseload. Yes? Got caseloads of 20 or less, 6 face-to-face contacts. The employment specialist or job seeker needs to be meeting with an employer within 30 days, multiple weekly treatment team meetings, variety of supports provided by a variety of people, and you must have local collaboration with your VR office and counselor. So I know we're right about 2:40 here, and you've probably found that I'm trying to pick up the pace a little because we have some information to cover. I wanted to point you to this pretty great article in Psychiatric Rehabilitation back in the spring of 2013, and it really looked at how VR and mental health IPS programs who were strong collaborators, what they looked at. Well, A, the expertise, training and technical assistance. This is stuff we haven't done before, and we need training and technical assistance. Consistency, that simply means how well we're implementing it. Joint referrals, in other words, we're jointly intaking people, whether that's through a formal or an informal process. And then finally, great collaborators integrate across their systems in mental health and employment. And there were 5 recommendations that came out of this kind of anecdotal research as well. Again, this is Psychiatric Rehabilitation, March 2013. And that was mutual knowledge, as we talked about before, between VR and IPS practitioners, that we might need to examine and modify VR regulations, and it's certainly the case in the states that I work in, and certainly here in my own state, that there are clear guidelines for the way that they participate on IPS teams, that we're focusing on good relationships, and that we're developing tools that both promote accountability but also help us collaborate more for these job seekers that both, again, mental health and VR traditionally have not served all that well. So here are just some of those pitfalls, some of those things that I wanted to point out to you for teams or organizations that are utilizing this approach. It is team-based. I can't say that enough. If you try to do it in isolation, you'll get poor outcomes. In some cases, VR and mental health have been implementing shared practices, but sometimes those haven't been evidence-based, and you have to collaborate around the evidence-based approach. Needing training and technical assistance is just part of this. I know as a provider, I've always valued getting an outside person to kind of look at how we might improve what we're doing. I'm not going to go through each one of these. Where I will point you to is this is adapted an excerpt from the VR Supportive Employment Partnership kind of pamphlet, and you'll see that the website's there. If you just Google, though, Ohio Supportive Employment Community of Excellence, you can pick this up. But what they looked at were 3 levels of engaging around mental health employment, IPS, with a mental health agency and with their local VR office. And these levels go through the basic, intermediate, and advanced. And it has different metrics here, right? How the local VR office designates a counselor, how they meet, how they do intake, and really looks at developing a plan and all that and puts some numbers on it. And I think it's worth looking at if you're struggling to kind of find a starting point between community mental health and local VR offices. As you see, there's again some metrics here that SE authorizations are developed within 60 days. And it goes on and on through intermediate, as I mentioned, all the way through to advanced. And all of these build upon one another, right? So if you're moving into expectations related to level 2, then you obviously have to meet everything that has been specified in level 1. And we'll make sure that we send out the website address to everyone. But it's important, I think, to look at these as ways to possibly start looking at the collaboration between these systems. When you get to this advanced or comprehensive stage, you're really, truly participating around the core principles of IPS and in addition, changing both mental health approaches and VR approaches to serving joint consumers. And these I'll just leave up to you. Here it is. It's a little clearer here. It's www.ohioseccoe.case.edu. And again, if you're more of a Googler, just Google Ohio Supportive Employment Community of Excellence, and that's going to pop up. All right, so I wanted to make sure before we save some time here, and I'm not sure we're going to get through the entire presentation, but as I mentioned, this is not just programmatic. It's also about stakeholders in the agencies. And this language comes directly from the Fidelity Review. So you'll see here the executive director and the clinical director have to understand the core principles we've just talked about. They have to demonstrate knowledge of that. That's not something we focused on in the past. And you can see how that shifts fundamentally what leadership is thinking about. The second bullet, again, comes right from the Fidelity Review. Someone has to participate actively in the SE Steering Committee, right? And that committee is responsible for writing action plans aimed at improving fidelity, expanding fidelity, expanding the availability of IPS. This comes right from the Fidelity Review. In other words, they get scored. This is one of my favorites. Not only is the CEO or executive director knowing the core principles, but they have to show how they are supporting the mission of the agency and articulate clear goals at least annually. It's something, an agency meeting, newsletters, but they cannot delegate this to another administrator. If they choose to do that, then they will get a lower score on their Fidelity Review. Again, the SE program leader comes right from the Fidelity Review here. They meet with the CEO at least twice a year to be able to talk about the things that are working well in the program and the things that they need leadership, the agency support in changing. Those are the expectations. This is not a great slide. I apologize for that. But this is a item right out of the Fidelity Review as well, related to how the employment specialist in the mental health agency is gauging VR. So you get a 1 to a 5 on every one of the Fidelity items. 1 is not as good, yes, than a 5. In this case, if they're just barely meeting with the VR counselor and they're not doing that very often and they're doing it less than quarterly, they're going to get a 1. And to get a 5, you must be meeting face-to-face. It must be scheduled. You have to have monthly client-related contacts, and they're weekly meeting to discuss shared clients and referrals. So I wanted you to be able to see that. It's that concrete in the Fidelity Review. So just some tips. Some of you have probably already done this, but if you haven't, I would certainly encourage reading and discussing the NAMI Road to Recovery. There's the website for it, Employment and Mental Illness. That's www.nami.org/work. It's got a great discussion of these topics and even some sample things to use with your local representatives and legislative body. And then to build upon this idea of peer specialist staff and then train the recovery workforce in IPS. I do that here through our Certified Peer Specialist program. And then finally, the one that I think is really at the forefront every time something awful happens that gets into the news, and that is how do we engage local and state businesses in conversations around stigma and the myth of mental illness and the impact that has economically on local economies. And if you're looking for something like that, SAMHSA has a great, the Substance Abuse and Mental Health Service Administration toolkit on how to have discussions around mental illness in a local community. Very important because it has a direct correlation to how we then end up doing job development. So there's the contact information. I am more than willing to email back and forth, or if I can be of any further assistance, I certainly want you to contact me. There are a couple numbers there. 2 different emails, one for Griffin-Hammis and, of course, one for UGA. So I will turn this back over to David and Jessica. If we have anyone who wants to comment or has a question or a reaction, we'd be more than happy to entertain those.
Doug, thank you very much. We gave you a lot of topics, and you put a lot of information there together in a 50-minute presentation, so thank you so much. I'm not even going to trash talk the Hoosiers or Georgia Bulldogs, so I'll leave you alone there. I was glad to have you with us, though. Hey, Doug, could you share a little information about what Georgia is doing with funding IPS programs across the state and what the funding piece looks like in Georgia?
Sure, absolutely. So in Georgia, as I said, under the Department of Justice settlement, adult mental health was required to use IPS Supportive Employment, and so we use really block grant funds for upfront intensive services in IPS. But over the last 2 years, we started really working together across VR and mental health, and I facilitated these groups, and we've developed a blended model now that looks at who pays for what. Yes, and certainly we're not the only state to do that. You have examples, again, all across the country. But here we really try to back out our slot money during the phases of job development. VR here in Georgia, like many VR state agencies, is based on a milestone approach. And so we blend over that time the general state funds, our slot funds, and block grant dollars into what is not being covered, and VR picks that up in between the milestones. So that has taken some time for providers to get used to who to bill when, and we're really just starting to delve into that. I will be honest with you, 2 years ago when we annually have a review by the Department of Justice, adult mental health was implicitly, emphatically told to get a relationship with its state mental health agency. So for the first time in the history of Georgia in mental health and VR, we're looking at transferring funds, at helping VR draw down more dollars to specifically then find and train VR counselors in IPS supported employment. I hope that answers it a little bit.
Thank you. Just talking out loud here for a second, but one of the things that we've been challenged with in Iowa over the last 3 years as we've moved the Employment First initiative forward is kind of the philosophical challenge that everybody can work. That there's something for everybody, and it's our role to find, identify their talents and abilities and work with business needs and make that happen. So you had kind of started off the presentation sharing, some thought-provoking ideas, and I'm going to give you a chance to go back and hammer home the core principles again. But as you talk about zero exclusion and that employment is essential to treatment and recovery, and you look at candidates that walk in the door of our mental health programs, our community providers, our VR agencies, our schools that are struggling with sobriety issues, struggling with criminal convictions, struggling with multiple mental health diagnoses, and we implement employment versus our traditional, job readiness type of concept. I'm going to give you a chance to talk a little bit more about that and hammer home, because I think this is a pushback that we get all the time.
Sure, David, and it truly is the challenge. And I tell people all the time, I believe in employment so deeply coming from a farm family and a union family. I think we know how important it is. And I think from a values philosophy standpoint, we can say, yes, zero exclusion. But when it comes down to someone who's actively hallucinating, who might be smoking weed and self-medicating, drinking, that's where, right, only the team can answer that. And so when I do training here with our VR counselors across the state of Georgia, I will often get this. Someone will stand up and they'll say, you're telling me that somebody can go to work drunk come in my office and be belligerent, and I say, I can't remember in the presentation where we said that. What we are saying is that we can exclude people based on those old stability issues. And if that's the case, yes, if that's the challenge, then it has to be a team supporting that person. Otherwise, the likelihood of that person with those multiple barriers succeeding is slim. But I also say this to people. I can count on one hand over the last decade, specifically in here in Georgia, where we had a job seeker who said, I want to go to work, and they still had lots of issues around medication, around those old notions of stability. And when that happens, of course, you have the team to discuss that. The real challenge is we have to fundamentally shift how we do employment and mental health from discharge aftercare to part of treatment and recovery. And that will come with some times when even I say, gosh, I don't know if the timing is right for this person. And of course you have those discussions with the team. Timing is different than setting up readiness hurdles. And I think that's the way we have tried to have conversations with our own two systems and locally when we're having those issues.
I think that's a great way to end it, and that will leave us some abilities to have some discussions at our local team levels and local communities about how we can continue to integrate these practices to make a difference in the system. I think the other thing, Doug, and you highlighted this a couple of times, the practice and the data supports that this is making a positive difference in the lives of individuals. So thank you so much for sharing some time. I'm going to turn it over to Jessica, who's going to make some closing comments in terms of our survey and making sure you know how to access the materials, and as well as a foreshadowing of what's to come. Thank you, Doug.
Thank you, David.
Thanks, Doug, and thanks, David. And thank you, too, to everybody that joined us today, and again for muting your phones. I just really appreciate it. I'm going to draw your attention to the survey or evaluation questions that we've got posted here. We hope that you respond, and that those are very helpful for us, especially if you have any recommendations on topics or things you want to hear in future webinars. If you weren't able to share your name and location at the beginning, you can still do that there in that pod. And again, we always appreciate that. In order to download Doug's presentation, you can do that there in the file pod in your bottom left-hand corner. But again, I'll send that out later this week with the transcript. And I will also send out the link that Doug referenced, the Ohio Supportive Employment. I'll pull that out of the presentation for you guys and include that in the body of the email that comes out. I think that covers everything, and then we hope to see you again in April on the 28th to talk about the role and importance of parent engagement in individualizing employment outcomes. And we'll be joined by Deb Sampson and Kelly Von London. I hope I say that right. And again, that'll be from 1 to 2 on April 28th, and I'll send that connection information out shortly before that date. I'll leave the room open again so you can provide your feedback and download the presentation. And we'll be talking with you soon, and thanks again for joining us.